Hello everyone, we'll discuss here the new asthma guideline and we'll start with a clinical case scenario.
This is a 6-year-old boy with history of eczema and allergic rhinitis has cough on and off. The cough is worse early in the morning and when playing. Family history is positive for seasonal allergies. Physical examination, the lung is clear to auscultation. Skin is dry with significant erythema, thickening of the skin and the scales on both arms and knees. What is the most likely diagnosis? Acute sinusitis, asthma, pneumonia, allergic rhinitis, foreign body aspiration. The correct answer is asthma. This child has atopy, eczema and allergic rhinitis. His cough early in the morning and when doing exercise. There is a positive family history of allergies and he has eczema in the physical exam. Asthma is a chronic inflammation of the airway. Asthma can be transient with early onset at age less than 1 year of age with decreased lung function at birth, then start to be better, resolve symptoms by mid-childhood, and no further reductions in pulmonary function. Also, asthma can be non-atopic without atopy, and with early onset at age less than 3 years of age with variable clinical course. Asthma can be late onset more than 3 years of age with variable clinical course. Asthma can be persistent starting early age, less than 3 years of age, with abnormal lung function by age of 3, and most patients are atopic. Asthma symptoms are more common in boys before puberty, but more severe in girls after puberty. Parents always ask this question when their child newly diagnosed with asthma if this child will have asthma all his or her life. To answer this question, you need to know about asthma predictive index. Asthma predictive index will help predict which children would be likely to develop persistent asthma symptoms. It is positive if one or more major risk factors. Major risk factors are parental history of asthma. One of the parents is having asthma or had asthma when they were younger, atopic dermatitis, eczema, sensitization to aeroallergen, or two or more minor risk factors. Minor risk factors are sensitization to food, more than 4% eosinophilia, wheezing apart from upper respiratory tract infections, so they can wheeze easily without having common cold with viral infection. Before we proceed further, we need to know the pathophysiology of asthma. Asthma is two components, inflammation and bronchospasm. Bronchospasm, when the body is exposed to allergen, the allergen will stimulate the IgE. IgE is the most important immunoglobulin in case of asthma. IgE will stimulate mast cells. Mast cells will release vasodilator. As you see here, the airway is widely open. Air can go in and out. When the vasodilators goes to the airway, will cause edema and vasodilatation of the lining blood vessels and edema, and this will make the airway narrow. Plus, will stimulate the smooth muscles in the bronchi and the bronchioles and will cause bronchoconstriction. So you have two components here, edema, vasodilatation, plus bronchoconstriction, vasodilatation, edema, and bronchoconstriction. This will make the airway narrower. In addition to that, because of the vasodilatation in the lining mucosal cells, this will produce more mucus secretion, and this will make it even harder to breathe. And in addition to that, you will have inflammation. The inflammation part will be mediated by inflammatory mediators, IL-5, IL-4, TSLP, IL-13, IL-33, and this will produce lymphocytes, eosinophils, mast cells, neutrophils, macrophages, smooth muscle cells, epithelial cells. So you have two components here, bronchospasm and inflammation. That's why when you manage asthma, you need to give bronchodilator to open the airway, and you need to give anti-inflammatory. Like, for example, inhaled corticosteroids. In severe cases, you need to give oral corticosteroids. Viral respiratory infections are the most common trigger of exacerbations in children, especially young ones less than 10 years of age, and have been associated with future development of asthma. Also, bronchiolitis, acute bronchiolitis with RSV infection and rhinovirus in early childhood increases risk of developing asthma. In older children, the most common virus triggering asthma is rhinovirus. Most common triggers of asthma: food allergy, Irritants such as tobacco smoking, even if the parent said we smoke outside, doesn't work. Air pollution, medications such as non-steroidal anti-inflammatory medications such as ibuprofen, beta blockers, viral respiratory infections with rhinovirus being the most common. Rhinovirus, high yield, the most common trigger of asthma. Exercise induced asthma or bronchospasm. Exercise can trigger asthma. Inhaled allergens such as pollens, pet exposure, dust mites, cockroaches, mold. Seasonal changes in weather can trigger asthma as well. Classic symptoms of asthma: wheezing, chest tightness. Young children may perceive chest tightness as chest pain, very common. Shortness of breath, cough. Symptoms are usually worse at night and early morning. If the child is having cough only or sputum production, chronic sputum production, you have to broaden your differential and look for other causes. Physical findings in case of asthma: wheezing, very important, especially when the child is sick and having acute asthma exacerbation. You may make it easy to hear the wheezing better if you ask the child to do forced exhalation or strong expiration. This will be helpful in older children and adolescents. Sometimes it's hard to hear the wheezing in this age group. You may see signs of atopy such as allergic shiners, rhinitis on the nose, or eczema on the skin. Pulmonary function test will help in making the diagnosis, especially if the diagnosis is not clear in older children more than 5 years of age. Exercise challenge can be used to evaluate for exercise-induced asthma. And you can do spirometry after the exercise to document a drop in pulmonary function after the exercise. Allergy testing should be considered and is important to be done, especially for children with persistent asthma or recurrent wheezing. This can identify allergic factors that may significantly contribute to the asthma, such as having dogs and cats at home if the child is allergic to the cat or the dog or both, or allergy to the environment. Chest X-ray is not required to make the diagnosis of asthma. In case of asthma, X-ray may show hyperinflation, increased bronchial markings, evidence of parenchymal disease. Atelectasis is very common, sometimes misunderstood as pneumonia but is not. It may show complications of pneumonia or congenital anomaly as the cause of wheezing, or foreign body aspiration as the cause of wheezing. Pulmonary function test, PFT or spirometry, is very helpful in making the diagnosis of asthma in children more than 5 years of age. Again, to emphasize on reading of volume time curve, this is the volume in liters. This is 6 liters maximum. This is the time in second. This is the first second. You ask the child to exhale the air as quickly as forcibly as possible. This is normal. The child was able to exhale most of the air out of the lung in the first second, like for example 80%. The child with asthma will not be able to do that. You ask the child to exhale as quickly as possible. So the child was not able to exhale most of the air out of the lung in the first second. For example, here 60%. So this is a case of asthma. Reduced FEV1 and normal FVC. This is asthma. For a child with asthma, you will ask the child to breathe in with maximum inspiration followed by fast and quick expiration, like that. The child was able to do successfully the inspiratory normal, but on expiration, the curve going down with concave. This is abnormal. This is a case of asthma, and the more the concave, the worse is the asthma. So this is how to understand the flow volume loop. Exercise induced asthma. Poorly controlled asthma may worsen with exercise. Asthma with exercise can be the only presentation, and this is very common. Symptom may start during or after exercise. Symptom may last about 90 minutes or longer after the exercise. Management of exercise-induced asthma: warm-up. Very important to do warm-up period for 15 minutes before exercise, and wearing a scarf or mask may reduce the symptoms. In 80% of patients, short-acting beta agonists such as albuterol before exercise will prevent the symptoms for about 2 to 3 hours. Multicast or singular can lead to decrease in bronchospasm in about 50% of patients, but the onset of action is several hours after the administration. Management of asthma. Assessment and monitoring of asthma. After initial diagnosis, review response to therapy to inhalers and allergy medications, reassess severity of the asthma, and control adjust therapy to reduce impairment and risk. Our ultimate goal, to use the lowest effective dose possible, especially of inhaled steroids. Periodic reassessment recommended due to variable nature of asthma. The asthma will vary from one child to another, and the response to therapy will vary from one child to another. Reassess patients every 2 to 6 weeks initially. In the beginning, every 2 to 6 weeks to gain disease control, to see how they are using the controller and relievers. Then every 1 to 6 months, depending on the patients and their compliance. Evaluate the technique. Ask the patient to practice in front of you. How do they use the inhaler with aero chamber? And compliance with controller therapy. Pulmonary function test is recommended at initial assessment, then 3 to 6 months after treatment and stabilization of symptoms. Also recommended during periods of uncontrolled symptoms, and at least every 1 to 2 years thereafter. Very important to know that inhaler technique and the correct use of the inhalers with or without the aero chamber is the most important step in the management of asthma, because poor inhaler technique results in poor asthma control and more frequent exacerbations and adverse effects. Be familiar with all types of inhaler. This type of inhaler is pressurized meter dose inhalers. So it's under pressure. So you press here, you apply pressure in this area, this spray will come out of this area. So you are able to use it with aero chamber, also is well known as HFA inhaler. So this is a pressurized inhaler. Is a spray. You are able to use it with aero chamber. Using the PMDIs or the HFA inhaler with a spacer or with aero chamber improves the delivery of medication and decreases side effects in all age groups. You will never go wrong using this inhaler with aero chamber at any age. Be familiar with aero chambers and spacers. This is an aero chamber with mask, and this is aero chamber without mask with mouthpiece. Most of them you are able to use with mask, without mask. As you can just put the mask here and remove it, you will have the mouthpiece under. So you can have the inhaler with mask, and you can able to use it with or without mask. But with mask should be used for all younger children less than 3 years of age. Without mask, with the mouthpiece only, most of the children older than 5 years of age will be comfortable using the aero chamber with mouthpiece only, without mask. This is a dry powder inhaler. This inhaler now more common, more popular, and the child will apply pressure in this area until it goes down. Then you will hear a click, and then they have to seal their mouth around this area. And now one dose is loaded already and is ready to inhale, and they have to suction, and they hold their breath for 10 seconds, as long as possible. Then they let go. Then they have to rinse their mouth with water after. So this is called the dry powder inhaler. Unfortunately, this inhaler or this type of inhalers are not appropriate for younger children less than 5 years of age. Asthma medications, beta-2 agonists, short-acting beta-2 agonists or SABA. The onset of action is within 15 minutes. Within 15 minutes start to work and last between 3 to 4 hours, short duration. Examples: albuterol, levalbuterol, and salbutamol. Long-acting beta-2 agonists, LABA. LABA is a long-acting, lasts for at least 12 hours and used in combination with inhaled steroids. Examples: salmeterol, formoterol, and vilanterol. Very important to know with the current guideline now, combined LABA and inhaled corticosteroids are recommended in patients who are not doing well in inhaled corticosteroids alone, and doubling the dose of inhaled corticosteroids by itself is no longer recommended. Potential side effects or adverse effects of beta agonists in general: short-acting and long-acting, agitation, irritability, tremors, insomnia, tachycardia, arrhythmia, and agitation, hypokalemia. Patients with diabetes mellitus are at risk of developing hypoglycemia. Inhaled corticosteroids, they are the most potent and effective medication for long-term control or management of asthma. They effectively decrease airway inflammation. This is the best and most important action. They decrease bronchial hypersensitiveness to allergens. They relieve asthma symptoms. What is really important, they improve lung function. Compare that to the excessive use of beta 2 agonists by itself like albuterol. In cases of uncontrolled asthma, the lung function will decrease, will decline. Very important to teach the parents. Examples of inhalers with only inhaled corticosteroids, for example, fluticasone, mometasone, budesonide, or well known as Pulmicort, beclomethasone, well known as QVAR. Adverse effects of inhaled corticosteroids: high dose and continuous using of high dose can cause slowing growth, but they can catch up during their growth spurt, so they will reach their final adult height, most of the children. Oral thrush is a common complication. To prevent that or to help to decrease that, by rinsing the mouth after taking the medication, or using a spacer may help. Osteoporosis, using high dose of inhaled corticosteroids or excessive use of oral steroids. How to prevent that? Of course, by compliance, by follow-up, and by always stepping down in the medication if the child doesn't need the high dose. This will prevent all these complications. Also, exercise, adequate calcium intake, and vitamin D can decrease the risk of osteoporosis. Inhaled corticosteroids LABA combination. This combination reduces symptoms and improves the lung function. Historically, we used to use it as controllers. With the new guideline, now we are able to use it as needed or as reliever. Examples: fluticasone, salmeterol, well known as Advair. It comes in HFA or discus or powder. Budesonide and formoterol, Symbicort. Mometasone and formoterol, Dulera. Most recent asthma guidelines now recommend the use of maintenance and reliever therapy, well known as MART. So you are able to use this combination as maintenance on daily basis, and when the child start to have cough, they can use it as reliever, well known as MART. The only combination you can use, inhaled corticosteroids with formoterol. You cannot use that with salmeterol, only formoterol, because it acts fast. It acts fast. But salmeterol, it takes longer, so cannot be used as needed. So this combination only, ICS plus formoterol, is the only one can be used as maintenance and as reliever as needed. Also, you are able to use it as just as needed only without maintenance. It is well known as anti-inflammatory reliever. So you are able to use this combination, ICS and formoterol, as air therapy. So air therapy only as needed. MART therapy, both maintenance and reliever as needed. With the new guidelines, air therapy, which is anti-inflammatory reliever, can be taken when symptoms occur like cough, shortness of breath, symptoms of asthma, or before exercise to prevent cough or asthma attack during or after exercise, or allergen exposure. So you can use air therapy, anti-inflammatory reliever as needed. The air dosing, one inhalation of the combination, of course the one with formoterol, whenever is needed. The maximum number of recommended total daily dose, including the maintenance, before seeking medical attention: 8 puffs for children 6 to 11, 12 puffs a day for children more than 12 years of age. We'll continue our discussions about leukotriene antagonists, Montelukast or Singulair. This is a very important medication, we need to learn about it. Leukotrienes acts as a potent mediator in inflammatory response. This medicine will block these reactions. So leukotrienes acts as a potent mediator inflammatory response, leading to bronchoconstriction, vascular permeability, increases the mucus production and activates inflammatory cells. By giving montelukast, this medicine will block all these reactions. So it will decrease inflammation, will block leukotriene D4 receptor. Usually used as add-on therapy, not preferred to be used for mild cases of persistent asthma. Children may benefit from that with allergic rhinitis, recurrent viral-induced asthma exacerbation, specifically exercise-induced asthma will benefit from using montelukast. Very helpful. Very important before prescribing this medicine to discuss the black box warning, which is serious mental health side effects like mood changes, aggression, depression, suicidal thoughts. So you have to discuss with parents the benefit versus the risk of using this medicine. Long-acting muscarinic antagonists or LAMA. LAMA is add-on therapy. LAMA improve lung function, reduce exacerbation rate, modestly improve asthma control when added to inhaled corticosteroids and LABA therapy. LABA is long-acting beta agonist therapy. So it is recommended to use as add-on therapy, not by itself. It is highly recommended for patients with moderate to severe asthma who are difficult to control or with uncontrolled asthma. Recommended as add-on therapy in patients more than 6 years of age. Example, tiotropium. Adverse effects: dry mouth, pharyngitis, upper respiratory tract infections. Management of acute asthma exacerbation. Mild to moderate exacerbation. The child will speak in phrases and sentences. No agitation, tachypnea. Prefers to sit than lay down. Oxygen saturation in room air more than 90%. Peak expiratory flow rate more than 50% of best of the 3 readings. Severe exacerbation, the child will speak in words, not in phrases. Shortness of breath, sitting, hunched, agitated, accessory muscle use, tachypnea, tachycardia, pulsus paradoxus, this is a bad sign, more than 20 millimeter of mercury. Oxygen saturation less than 90% in room air. Peak expiratory flow rate less than 50%. Life-threatening exacerbations or status asthmaticus. You listen to the chest, there is no wheezing, silent chest, no air movement. This is a very bad sign. In combination with drowsiness, confusion, fatigue, the child looks tired, hypoxic. This is a very bad sign. Chest X-ray is not recommended routinely in management of asthma, but if it was done, it may show atelectasis, which is very important to be differentiated clinically from pneumonia. Very common on a chest X-ray to see atelectasis in cases of asthma. Home management of asthma exacerbation. Very important to provide the parents with written asthma action plan. Read it for them. Ask them to read it back to you to make sure they understand the plan. When you have a child with asthma exacerbation, you can use air therapy, which is anti-inflammatory reliever therapy with ICS and formoterol, or increase the short-acting beta agonists like albuterol for increased symptoms. Very important to ask the parents to seek a healthcare provider or to come back to the office if no response or worsening in the next several days. Very important to know no significant benefit found in increasing the dose of inhaled corticosteroids by itself in children between 6 and 11 years of age with the new guideline with good inhaled corticosteroids maintenance adherence. So the child between 6 and 11 using the inhaled corticosteroids every day, compliant, use it correctly, so there is no need to increase the dose of inhaled corticosteroids. So instead of that, you will give a combination of ICS formoterol better. This is with the new guideline. Teens and adults may benefit from high dose of inhaled corticosteroids for 7 to 14 days during exacerbation instead of giving oral steroids. Oral corticosteroids may be recommended for 3 to 5 days for patients who fail to respond to reliever therapy for 2 to 3 days or have worsening lung function, for example, peak expiratory flow rate less than 60%. Office management of asthma exacerbations. This slide is very important for all pediatricians. Mild to moderate acute exacerbations, we will give repeated administration of short-acting beta agonists, for example, albuterol. You will give 4 to 10 puffs of albuterol with a spacer or aero chamber or nebulized treatment every 20 minutes times 3. You will give systemic steroids or oral steroids 1 to 2 milligrams per kilo with maximum dose 40 milligrams. Oxygen therapy as needed to keep oxygen saturation more than 94 to 98 in children, 93 to 95 in adolescents. Then reassess the response to this therapy after 1 hour. Discharge home if symptoms are better, not needing albuterol anymore in the office. Peak expiratory flow rate improved more than 60%. Then adequate home resources. They have medicine at home, they have nebulizer at home, they understand how to use these medications. Very important. Follow up within 1 to 2 days. Complete a course of oral steroids for 3 to 5 days. Severe acute asthma exacerbation or worsening patients should be transferred to acute care facility or to the emergency room. Meanwhile, during the process of transfer, start acute therapy as above while awaiting for the transfer. Add high doses of ipratropium bromide if is available. Initial controller therapy according to the new guideline GINA 2023. Initial preferred therapy. For age 6 to 11 years, if you have symptoms less than 2 times a month, the preferred treatment to short-acting beta agonists like albuterol plus low-dose inhaled corticosteroids. If you have the symptoms of more than or equal 2 times a month but not daily, the maintenance therapy will be daily low dose of inhaled corticosteroids, and the reliever will be albuterol as needed or short-acting beta agonist as needed. For adolescents more than 12 years of age, symptoms less than 4 to 5 days a week, the preferred therapy or preferred initial therapy, low dose inhaled corticosteroids formoterol as needed, which we will known as air therapy. Initial preferred therapy step 3. If you have age 6 to 11 year, symptoms most days or more than or equal 1 night a week, maintenance will be daily low dose or medium dose ICS or daily low dose ICS LABA combination or daily very low dose ICS formoterol, and reliever will be short-acting beta agonist as needed or air. Air means ICS formoterol as needed. For step 3, age more than or equal 12 years of age and they have symptoms most days or more than or equal 1 night a week, the maintenance will be low dose ICS formoterol daily and reliever will be air. Air means the same, will be ICS formoterol but as needed. Step 4, initial preferred therapy, 6 to 11 years. If the child is having symptoms every day or more than or equal 1 night a week with low lung function, refer to specialist. Maintenance therapy will be daily medium dose ICS and LABA combination or daily low dose ICS formoterol as MART therapy like maintenance. Reliever, which is short-acting beta agonist as needed, or air, which is the ICS formoterol as needed. For 12 years and older, symptoms every day or they have more than or equal 1 night a week with low lung function, the maintenance will be medium dose ICS formoterol on daily basis as maintenance, and reliever will be the same medicine but air as needed. Step 5, initial preferred at age 6 to 11 year, uncontrolled asthma on lower step, refer to specialists for evaluation and consideration for high dose ICS LABA or add-on therapy, including biologics or oral corticosteroids. Maintenance will be medium high dose or ICS formoterol, and the reliever will be air, which is ICS formoterol as needed. More than or equal 12 years of age, uncontrolled asthma on lower step, the maintenance will be high dose ICS formoterol, and consider add-on therapy with LAMA and specialist referral for further evaluation plus or minus biologic and air therapy as needed. This is a 6-year-old boy is seen for follow-up on asthma. He is taking inhaled albuterol as needed for coughing and wheezing. oral Montelukast every night, using fluticasone inhaler on daily basis with aero chamber correctly. But he's still coughing, and the cough is worse with exercise. What is the next best step? Repeat the 5 days course of oral steroids, 1 dose of dexamethasone in the office, increase the dose of inhaled fluticasone, combined inhaled steroids and formoterol inhaler daily and as needed. The correct answer, as we mentioned before, according to the new guideline, not to increase the dose of inhaled corticosteroids by itself. There is no benefit to do that for children 6 years and older. Instead, give combination of inhaled corticosteroids and formoterol to use as maintenance and as needed as well. Management of asthma in younger children less than 5 years of age. It is important when you make the diagnosis of asthma in this age group to exclude other diagnoses, such as congenital lung diseases, for example. Most likely to have asthma if they have 10 days of cough, you hear wheezing in physical exam, heavy breathing, with the following: URI more than 3 episodes per year. So they have URI, then they start to wheeze. Severe episodes of wheezing and cough, symptoms worsen at night, or symptomatic episodes between URIs and they have signs of atopy. So the wheezing is not just triggered by URIs, no, in between also, and they have signs of atopy. For example, eczema, food allergy, family history of asthma, allergic sensitization. Step 1, in patients with recurrent symptom but less than 2 times a week, prescribe short-acting beta agonist as needed plus low dose of inhaled corticosteroids at the onset of viral illness. Step 2, daily low dose of inhaled corticosteroid recommended for more frequent persistent symptoms for at least 3 months. Then step 3, re-evaluate for alternative diagnoses, check inhaler technique, very important, and aero chamber use as well as the adherence. Inquire about risk factors. Double the dose of inhaled corticosteroid therapy. Consider referral to a specialist. Step 4, reassess modifiable risk factor, like for example, do allergy test if they have dogs or cats at home. Refer to a specialist. Factors associated with increased risk of death from asthma. Very important to know and very important to teach parents. High use of short-acting beta agonist, more than or equal 1 canister per month. So using more than 1 inhaler of albuterol per month is associated with increased risk of death and decline in pulmonary or lung function. In children, non-Hispanic blacks are more likely to die from asthma compared to other racial and ethnic groups. Previous exacerbation requiring intubation is a very bad sign. Hospitalization or ED visit in the past year. Recent use of oral corticosteroids. So excessive use of oral corticosteroids in case of asthma is associated with increased risk of death. So the best to prevent that is to use controller maintenance therapy with inhaled corticosteroids with follow-up to step down in the therapy if it's not needed to continue the high dose. This is a 7-year-old male presents with throat pain, fever, shortness of breath, and chest pain. He has history of mild asthma using albuterol inhaler as needed. He cannot speak clearly without taking a breath between words. His oxygen saturation is 88% in room air. Respiratory rate is 33 breaths per minute. Physical examination, he appears tired, expiratory wheezing, and suprasternal retraction. What is the best next step? To start inhaled corticosteroids or in ICS with LABA, or to add on therapy, LAMA therapy, or refer to emergency department or give oral azithromycin. The correct answer, refer to the emergency department. This is a case of severe asthma exacerbation. Clinical presentation of severe asthma exacerbation or respiratory distress: paradoxical thoracoabdominal movements, abdominal breathing, severe airway obstruction or silent chest, bradycardia because of severe hypoxemia. Pulses paradoxes may disappear, and this will suggest respiratory muscle fatigue and the impending respiratory failure. Confusion: the child with asthma may become worse, drowsy, and confused. This is a bad sign. Adolescents may not have these symptoms of confusion and drowsiness until they are in frank respiratory failure. History of near-fetal asthma with endotracheal intubation is the greatest single predictor of death from bronchial asthma. Signs of impending respiratory failure: tachypnea, retractions, dyspnea, pulsus paradoxus more than 20 millimeter of mercury, normal or rising CO2. Normally you should have low CO2 because of hyperventilation. When it starts to be normal and rising, you know that the child is very tired to breathe. Anxiety, tachycardia, bradycardia in severe hypoxemia, drowsiness and confusion. Management of status asthmaticus: hospitalization with hydration, oxygen monitoring and therapy, beta-2 agonist, albuterol, continuous therapy, ipratropium, IV and nebulized steroids, magnesium sulfate.
This is the end of this presentation. Thank you for listening.
Having trouble or trying to pass the pediatric board exam? We have the definitive solution for you, presenting the Last Minute Review series, a powerful tool for achieving success in pediatric board exams, crafted by Dr. Osama Naga, a board-certified pediatrician by American Board of Pediatrics and the editor of the Pediatric Board Study Guide, A Last Minute Review. Dr. Naga breaks down the most critical subjects in this series. The Pediatric Last Minute Review webpage offers a thorough and rigorous set of pediatric board review sessions that are in line with the study guide. The lectures will cover the most important topics for each condition that a pediatrician must know for pediatric board exams, as well as real-life clinical encounters. The inclusion of a clinical case scenario, accompanied by multiple-choice questions, followed by the most probable answer and a comprehensive description of the issue, will ensure test readiness for each student. You will be able to download the lecture's PDF files to make your studies easier, to take notes and be accessible on the go and offline. Based on the membership plan you choose, you will have unlimited access to the lectures for either 1 month, 3 months, 6 months, or 1 year. By viewing these videos, you will increase your chances of passing the board exam and gain substantial advantages from the acquired knowledge. Additionally, by studying the material and completing the AAP prep questions from the previous 3 years, you will greatly increase your likelihood of passing the board and will acquire a wealth of knowledge. Click on the link provided below to visit lastminutepediatric.com and subscribe immediately. Be sure to take advantage of our free video samples on our YouTube channel, Pediatric Board Last Minute Review. Good luck with your exams!